Okay, everybody, let's get started. Welcome to today's Cardiovascular MR Journal Club webinar. I'm welcoming you from Montreal today. We have two interesting papers today, both on myocarditis and both on aspects that are not that well developed yet. As probably you all are aware, there has been a recent update of the Lake-Louise criteria that now include mapping, T1 and T2 mapping that can be used clinically, replacing the early enhancement and the usual T2 weighted images, and even allow for, because now two criteria are only needed and may allow for a non-contrast study. However, although these criteria have already been shown to be good and actually increasing the sensitivity, which was the goal of the introduction of the new criteria, and we have discussed these papers before, one aspect has not been covered in the past by many studies, but it may be important, and that is the pericardial involvement. We currently use it as a supportive criterion, but there have been papers in the past indicating that it may be more important. So that's why from Italy, from the Italian are important, and Gianluca Di Bella will talk about that. And then we have another aspect with more sophisticated analysis of the T1 and T2 maps, using innovative techniques, specifically, let's say, analysis. And, I'm very happy that Bettina Baessler is here to talk about that paper, which that was published in Radiology after that. As usual, I ask everybody to unmute themselves if they want to say something, but otherwise be muted. If there is a question, just unmute yourself and speak up, or type it into the chat window, then I will ask that. So with that, I want to say a big thank you already to Gianluca and Bettina for joining us and presenting their papers, and now hand over to Gianluca Di Bella to talk about the paper in Circulation Cardiovascular Imaging called Clinical Value and Prognostic Impact of Pericardial Involvement in Acute Myocarditis. Gianluca.
Okay, thank you for this opportunity to be here. About a year ago, we have published a manuscript regarding the role of pericardial involvement in patients with acute myocarditis. This paper, this manuscript, was accepted as a research letter, but we before have submitted it for as a full paper in circulation, and the editor suggested us to publish this as a research letter in Circulation Cardiovascular Imaging, and therefore I have other data about it. The manuscript, this study is a sub-study of the ITAMI study, that was a study that was organized by Italian Society of Cardiology regarding the role of CMR in patients with acute myocarditis and the prognostic role of CMR in this subset of patients with heart disease. In this sub-study, we enrolled about 1,400 patients, and have divided patients according to the presence of pericardial involvement. All patients are patients with a definite diagnosis of acute myocarditis according to Lake-Louise criteria, the old version of Lake-Louise criteria. And in this sub-study, we enrolled the patient with the acute myocarditis with a different clinical presentation, both chest pain, infarct-like presentation, arrhythmias presentations, a patient with heart failure presentation. According to the presence of pericardial involvement, we observed that about 25% of patients with acute myocarditis have a pericardial involvement. pericardial involvement was defined according to the presence of pericardial effusion more than 5 millimeters in diastole, and or pericardial enhancement in pericardium. And we have observed that patients with the pericardial involvement have a large left ventricular dimension, both in right ventricle, that in left ventricle. Patients with pericardial involvement showed a greater left ventricular dysfunction respect to those without pericardial involvement. And patient with pericardial involvement showed a large left ventricular damage, both in subepicardial layer than in middle layer of left ventricle. And we have observed, we have followed this patient about for 5 years with a median period of 2 years and 3 years, and observed that patients with the pericardial involvement have a great numbers of composite events, in particular to cardiac death, appropriate ACD, ACD activity, heart failure hospitalization. But when, and this can be observed also in Kaplan-Meier, in this figure, in panel B of the figure, patient with pericardial involvement, red line, had the worst outcome respect to patients without pericardial involvement. But we performed also a survival analysis at the univariate and multivariate analysis, and observed that patient with pericardial involvement and the worst prognosis, other important marker of worst prognosis were left ventricular dysfunction, defined as a left ventricular ejection fraction less than 40%, according to European guideline of heart failure, and another independent predictor, both at univariate and multivariate analysis, was anteroseptal late gadolinium enhancement. And therefore, these 3 markers, pericardial involvement, anteroseptal late gadolinium enhancement, and ejection fraction less than 40%, are independent predictor of cardiac events. And in figure 1, panel C and panel D, we can observe that we have made a sub-analysis of survival, in which can be observed that the presence of that patient having both left ventricular dysfunction and pericardial involvement had the worst prognosis with respect to patient to those having only one marker, or LV dysfunction or pericardial involvement. And this worst prognosis of 2 markers is observed also when we add pericardial involvement in patient with LV dysfunction, or when we consider pericardial involvement in patient with anteroseptal LGF. Therefore, we conclude that in patient with perimyocarditis, there is a worse prognosis with respect to patient with acute myocarditis alone.
Okay, thank you very much. So what you're regarding the clinical consequence, would you then say that we should include them into the diagnostic criteria? And have you also done or looked at patients that clinically present with just pericarditis, and where you looked at how many of those actually have myocardial involvement? Because that's sometimes a clinical discussion we're having. This patient has pericarditis, so there's pericardial effusion and there's a low voltage and all that. So we don't need to check for myocarditis, and then all of a sudden, oh wow, there's a troponin, and then there's myocardial involvement. So, and there's also the discussion whether does it start as a pericarditis and develops a perimyocarditis, or does it start as a myocarditis and develop and involves then the pericardium, or is it a process of both at the same time? So what are your thoughts on that?
Okay. Previous studies have shown that pericarditis, acute pericarditis with troponin elevation had a good prognosis. On the contrary, our study observed that the patient with acute myocarditis with pericardial involvement have a worse prognosis with respect to those without pericardial involvement. And probably these are two very different entities, the pericardial involvement alone with respect to pericardial involvement in patients with acute myocarditis. On the other hand, there is the possibility that pericardial involvement in the context of acute myocarditis represent a complex and disease with a more extensive damage, not only in left ventricle. In fact, we observe a large number of segments with late gadolinium enhancement in patients with acute myocarditis, but also regarding a diffuse involvement of myocardium, also in the area without late gadolinium enhancement. And I think that other technology, for example, T1 or T2 mapping, can help us to resolve this question.
Yeah, then another question, and then we'll have to move on to Bettina. And then I would also ask you to unshare your screen, Gianluca, so that Bettina can share hers. So you defined pericardial inflammation as hyperintensity on T2 weighted images. So, but you said 50%. So the clinical experience is not so much the 50%, but that's just a yes or no. So you said 5 millimeters, and then the 50% hyperintensity, is that really on both T2 and late gadolinium enhancement, or is it the 50% more for the late gadolinium enhancement? Just for the definition of pericardial involvement.
In our manuscript, we have considered pericardial involvement, pericardial enhancement, as you have said, involved at least 50% of the pericardium.
Please unmute yourself if you're not speaking, because someone is talking. And just continue, Gianluca, yeah.
And have considered only late gadolinium enhanced, but in clinical practice, there is also the involvement of T2 hyperenhancement in T2 images that confirm the edema of pericardium, and therefore both of these two markers in both in LG images and the T2 weight images can help us to make a definition of pericardial involvement. And
yeah, so sorry to interrupt, but the reason I'm asking is because on the T2 weighted images, the STIR images, for example, this triple inversion recovery spin echo technique, sometimes the flow suppression causes the pericardial effusion to almost disappear. And that's why I myself only go for the pericardial effusion in the cine images. So that's why I was interested in the approach of looking at the signal intensity of the pericardium in T2 weighted images, because I consider this technically, at least for probably for many centers, as a bit more difficult than just looking at the fusion. So would you think it would be sufficient to look at the fusion in the cine images, or would you say that you add cases looking at the T2?
We have observed the pericardial fusion in the majority of patients, and probably because it is more easy to identify pericardial fusion. Only 10 patients had left gadolinium enhancement in pericardium, and about 30 patients had both pericardial enhancement and pericardial fusion. I agree with your suggestion.
Okay, thank you very much, Gianluca. That was interesting. So if you could unshare your screen, so basically the same button used for sharing, unshare your screen so that Bettina can share hers. Okay. So now Bettina Baessler has relatively recently moved to Zurich and is now presenting from there the paper, and she has done some amazing work before on an advanced analysis of the texture of the left ventricle with respect to T1 and T2, specifically also looking at homogeneity and certain patterns. So it is very interesting now to hear from her. Gianluca, we still see your screen, so you will have to somehow unshare your, because otherwise Bettina cannot share. So you can also go on the top. There is top list. There is a meeting, and then there is a start share or a stop share option there. And sometimes there are two windows with Zoom, so you have to find the window with a share button on the bottom.
Otherwise, I could just try to share mine. Perhaps Gianluca's will disappear. I don't know.
Yeah. Oh, yeah. Or maybe he'll get a request then, but
yeah,
probably you.
I'll try it. So no, it doesn't work.
Yeah. So Gianluca, you will have to unshare your screen, or you quickly leave the meeting and then join us back. That is the other option.
Okay.
Great. So now it works.
Okay.
I have to find the right window. Too many open windows.
You can also just then share, although I don't recommend that, to share the desktop.
No, not a good idea. So I find the correct one. Okay, so.
Okay, looks like you're successful. It says here has started screen sharing. Okay, so here you are. Yeah.
Okay, so yeah, thanks very much.
We have, let's say, 15 minutes left, even if we go a little bit over time. So as for everybody.
Okay, great. So yeah, thanks for the invitation. It's a great honor to present this work. It's about texture analysis, so a bit of the new stuff in myocarditis, but in a special group of myocarditis patients. And it's the group of acute or chronic symptoms of heart failure. So it's not the acute infarct-like myocarditis, but the heart failure-like type. Why did we focus on this group? Well, I think this is our greatest challenge we are facing. So the infarct-like myocarditis patients, well, they are also a challenge, of course, but they are at least often identified clinically and using the Lurz criteria, especially in the updated version. But these patients presenting with symptoms of heart failure, either acute or chronic, are really a great challenge. So the current opinion goes more and more towards we have different subtypes of myocarditis. It's not a disease, but it's different types of disease which are summarized under the noun myocarditis. So we have these infarct-like patients, we have heart failure-like patients, we have arrhythmic patients, and everything in between. And potentially these patient groups should be treated differently also during the diagnostic workup. So why did we use texture analysis? Not only because it's fancy and new, but this is actually something which emerged during the work of several years. So I switched to previous publications very quickly in order to make better understandable why we did this. This was the initial work on tissue inhomogeneity and T2 mapping, where we elaborated the hypothesis that it's not that easy to use mapping in myocarditis. And it's not that easy because we have an inhomogeneous distribution of T2 values in the tissue, which might be overlooked if we average T2 times or T1 times across the entire myocardium, what is often done. So this was the initial work. We defined some fancy new parameters, handcrafted and so on. So, but the idea is still the same, to get quantitative parameters which reflect this inflammation-induced inhomogeneity of the myocardium. And then we did a first proof of concept study, which was also published in Radiology several months before, in this infarct-like acute myocarditis patient group, using texture analysis to quantify this heterogeneity. And this worked quite well. So this was our proof of concept, actually, to get to know if it works, if the concept itself is worth to be further elaborated on in a more difficult patient cohort. These are the results from this initial proof of concept study: biopsy proven patients with myocarditis versus patients with symptoms but no inflammation on biopsy. Here are the standard CMR parameters, so Lurz criteria, the old ones. Mean T1 and T2, none of them did really work very well in this patient cohort, but the texture analysis showed a really good diagnostic performance, especially when combined with blood parameters, so troponin, CKB, and etc. So this was very encouraging. And this was why we decided, okay, now let's have a look on this very difficult patient cohort. Maybe we have some parameters here as well, which reflect something we are not able to get on visually or by averaging something across the myocardium. What did we do actually? So this is the purpose of our study. We used anomyocardial biopsy as a reference standard, and that's perhaps something special about this study. And it is a sub-study from the MyRacer trial from Philipp Lurz from Leipzig, Germany. You maybe know this study already. The special thing about this study is that all patients got right and left ventricular myocardial biopsy. So we have a reference standard, at least if it's a good reference standard, it's for sure subject to discussion. But we included 79 of the initially reported 129 patients. And so we split the patient cohort, and you can see the inclusion and exclusion criteria here. So the inclusion criteria was symptoms of heart failure, either acute or chronic, then elevated levels of NT-proBNP. Patients had a history of viral disease. They were excluded to have CAT by in the cath lab either or by CT, coronary CT, and they had reduced LV ejection fraction below 45%. We excluded all patients which had previously in their history a CAT, which presented with infarct-like symptoms, and which had any contraindications to our study protocol. And then we divided our patients in two subgroups. One subgroup with acute symptoms. This was defined as below 14 days. This were 34 patients, and one group with chronic symptoms above 14 days. This were 45 patients, and most of them had symptoms for much longer than 14 days, but we had to find some sort of cutoff. They all underwent cardiac catheterization and exclusion of CAT and biventricular biopsy. One patient withdrew consent, and within 2 days they also underwent cardiac CMR at 1.5 T. Several dropouts there due to whatever artifacts, claustrophobia, whatever. And so finally we had two patient groups. 31 patients with acute myocarditis and symptoms of heart failure, of whom 21 were positive on biopsy, so had biopsy-proven inflammation, and 10 of them were negative on biopsy, so they had anything else, amyloidosis, whatever you can have in the heart, or nothing, or well. And the second group were 40 patients with chronic symptoms and myocarditis, and 26 of them were positive on biopsy and 14 were negative. So still small patient groups, I have to admit, but well, better than nothing. What type of imaging did we require? We, as I said, used a 1.5 T system, and we required a standard protocol, so CNEs in all axes, T2 stir images with a body coil, native T2 mapping, native T1 mapping using a MOLI sequence, 335 scheme, early enhancement, late gadolinium enhancement using a PSUR sequence, etc. So standard imaging. And yeah, so the Lake Louise criteria that were assessed in this study were also the previous version. So the update wasn't published the time we wrote the manuscript here, unfortunately. So it would be very interesting to compare this to the novel version of the Lake Louise criteria. And after the images were acquired, we used the Mazda software, which is open source, to extract regions of interest. And these regions of interest encompass the entire LV myocardium. So everything within the myocardium on T2 and T1 maps was included in two different views, so in a short axis view and in one long axis view. And then we did some normalization of these images, which is required and very important to do, so adjust the brightness, etc. So I won't go too deep into that. And then we extracted features, and we extracted around 300 features, which is not that much regarding radiomic studies, so you can do much more than that. In this table here, you can see some patient characteristics. LV ejection fraction, this was all not very different between these groups. So here are the acute ones, biopsy positive versus negative, here the chronic group. The single statistically relevant difference was, as to be expected, the CD3 or 68 plus cell count, so inflammation, because we divided the groups according to these parameters. So here was the inflammatory group versus the non-inflammatory group. Interestingly, there was no really significant difference regarding fibrosis or the percentage of fibrosis in the myocardium. It was higher in the chronic group, but this was statistically not different because of the, I think, the small groups. We did also some reproducibility analysis. This was also part of the multi-step dimension reduction and feature selection process, which came after the feature extraction. So you have 300 features, a whole bunch of numbers, and you have to do something with it. So the standard in these radiomic studies is to reduce the feature set in a multi-step process. So first comes reproducibility, because any parameter which is not reproducible doesn't make sense really clinically. Then you do some machine learning and correlation analysis, some clusters, and finally you end up with some features. And indeed, we ended up with some features. Here are some images from the different groups. I go over that a bit faster. And the results are actually summarized here. So here are our conventional, I say, parameters like Lurz criteria, mean T1 and T2 from mapping, so averaged across the entire myocardium. We see that this is the acute group, biopsy positive versus negative, and the chronic group here, that the Lurz criteria version 1 didn't work that well, but they weren't designed to detect heart failure like myocarditis. You have to say that. But also the mapping techniques weren't that good. So they at least did quite well in the acute group, at least T2 mapping with an area under the curve of 0.69, but this dropped in the chronic group. So this wasn't so convincing, I'd say. It's okay, but it could be better. And if you combine the two mapping techniques, this was also an interesting question, because I wondered whether this would add something to our diagnostic, but this wasn't significantly different to any of the single parameters. In contrast, there were different parameters selected for the two subgroups. So for the acute group, the most important features were mean T2 actually, so the mean here above, but in addition a texture feature from the co-occurrence, the run length matrix, so gray level non-uniformity is the name of this feature. And if you combine these two features, we end up with an area under the curve of 0.76, a 1% sensitivity and 71% specificity. And for the chronic group, we had two different features, which were the most important ones: T2 kurtosis from the histogram matrix and T1 gray level non-uniformity. And we ended up with an area under the curve of 0.85 here. So we have also some RC analysis. This is the acute group. Conventional parameters here, like Lurz in gray, the other ones in these other colors. And this is the texture analysis. Well, it's not perfect, but it's better than the conventional parameters in the acute group, and especially in the most difficult group, the chronic ones. So you can appreciate that we had, well, you could flip a coin actually to detect chronic inflammation by using our standard parameters, and especially the combination of these two features here from both T1 and T2 mapping, reflecting tissue heterogeneity, but by they are differently calculated, these two parameters, and if you combine them, you end up with a quite nice area under the curve. So yeah, here is the summary of our results. And so the conclusion is actually that text analysis might detect something you cannot appreciate visually, and you cannot appreciate by averaging values across the entire ventricle. Perhaps you get something which reflects this inflammation-induced heterogeneity. So I think it's worth to be validated in larger cohort, but it's quite difficult to get data. So it's not that easy to validate this in large cohorts. So yeah, we'll see how we get further on with that. But I think it's an interesting technique which is worth to be looked at.
Thank you very much, Bettina. I think this is definitely, this is a very good direction to go, because having now also gathered some experience with machine learning and data mining in signal intensity myself, it is really a field that offers a lot of very interesting opportunities, and you were one of the pioneers there. So really thanks for that great work, and there's more to be expected. Of course, you already mentioned some of the potential limitations. Is endomyocardial biopsy really a very good gold standard? We don't know for sure, because that's with all the stuff that we think are the gold standard. Who validated that against what? So it is always difficult. So that's why I think even if it doesn't look perfect, it may be an error more on the biopsy side and not on the side of the algorithm to detect the inhomogeneities. To me, it was interesting that most of the information was in T2, although you would expect that in chronic disease, there is probably a competition between fibrosis, which may lower T2, and edema that increases T2. So that's why the inhomogeneity to me makes definitely sense from a physiology point of view. So that's why but it was still surprising that there was more information. Not surprising, but interesting that there was more information in the T2 data. Now, have you also applied that to patients with other cardiomyopathies, where you, of course, may also have on a tissue level varying pathology? Have you ever looked at that? And of course, you could probably use the same data and then just calculate the accuracy for the new Lurz criteria. Although looking at the table, they may not turn out to be perfect for that. So
yeah, I also guessed that. Yeah, we did actually. So before we entered, or the first study where we entered this text analysis stuff and worked for the first time was patients with myocardial infarction. So we tried to detect actually scars on CNA imaging, and this worked also quite well. And there are several studies out now by different groups showing that. And we tried it in patients with HCM, because that's the same hypothesis. There is some inhomogeneity, some tissue structural abnormality, which we can get this by LGE, but sometimes you don't want to give contrast, or you are not able to because of kidney or whatever. So we used not mapping, but T1 weighted imaging, native T1 weighted imaging, and it also turned out that we could detect LGE on native sequences, or at least something which is potentially reflected on LGE. Yeah, and other groups did several different cardiomyopathies as well. Yeah.
I think that may be a huge value of these approaches, that eventually we can get rid of contrast agents.
Yeah.
Not only because of the cost and the safety, but also in younger patients, you do not necessarily want to give something that accumulates in the brain, even though we do not have any evidence for any damage or clinically meaningful implications. But we don't want that if we can get along without contrast agents. So that's I think a very important point you're making there. Okay, I think we're already way over time. Thank you both very much, Gianluca and Bettina, for joining. Before I let you go, I just wanted to point to the next CMR Journal Club in 2 weeks, which will be also about myocarditis in part, but we will mostly focus on strain imaging, which is another construction site in cardiac MR, We have several approaches. We have dense, we have sync, we have F-sync, we have feature tracking, we have tissue tracking. So we will discuss 2 papers next time, and Dr. Rabisch from Kiel University in Germany will present one of them. So that is on January 28, and then after that we'll have a break for the CMR sessions in Orlando. So with that's it. I wish you all the best for wherever you are. Thanks again to Gianluca and Bettina for joining, and I wish you a wonderful day or evening wherever you are.